So I have received some questions to discuss the answers. So we'll start with the questions which I got in order. So this was the first question. A case of intramural thrombus left ventricle, post-operative heparinization is indicated for all except. Actually, this is a very vague question. I'm not sure whether this was the original question, and also there are only two options. I think there are four options for all questions because there is the problem in this question is post-op heparinization. So what surgery is carried out, that is not clear. And we have to know the other two options also. Then only we can tell indicated for all except. So it's an incomplete question with only limited options. So I'm really confused how to answer this. The problem is if you see a suspected venous thrombus is always an indication for heparinization. Progression of ischemia is also an indication for heparinization. But when you see an intramural thrombus of left ventricle usually occurs after a myocardial infarction, usually after an MI, you have a left ventricle aneurysm and which harbor a thrombus. So that is a cause for intramural thrombus in the left ventricle. And the management is anticoagulation for 3 to 6 months and usually it resolves. So we give anticoagulation to start with heparin and then we change it to either oral anticoagulants or newer oral anticoagulant agents for 3 to 6 months. So here suspected venous thrombus, venous side thrombosis usually is not associated with this left ventricle thrombus. Because as I told, left ventricle thrombus is seen after a myocardial infarction and usually they get embolized into the arterial system. So venous thrombosis is not matching to this question. So I don't know whether that is the answer because I have to know the other two options. Then only I can tell whether this is answer to this or not. So this is a very vague question with incomplete options. So I'm not able to give a correct answer to this question.
Ma'am, in chat, we have participants saying one option was post-MI and the other one was risk of embolism.
Yeah, risk of embolism is definitely an indication for heparinization. Post-MI is definitely an indication for heparinization. Progression of ischemia is definitely an indication. So maybe this venous side thrombus is not matching with this situation of intramural thrombus of left ventricle because this is an arterial side. So I suppose that will be the answer. Suspected venous thrombus. That is indication for heparinization, but that is not in this context. Considering the context of intramural left ventricle thrombus, suspected venous thrombosis will not come in this context. So that may be the answer. Okay. So next is aortic valve stenosis, appearance of which clinical symptom is associated with less survival. So for this, there is a code like ASD. ASD means angina, syncope, dyspnea. So it is said that if a patient presents with angina due to aortic stenosis, not because of associated coronary, the lifespan is usually 5 years without management or without treatment. Syncope, the lifespan is 3 years. And dyspnea, why it occurs? Because of heart failure. So it is the end stage of aortic valve stenosis where the patient will develop severe left ventricular dysfunction and heart starts to fail, decompensated heart failure. Whether by that time the patient gets dyspnea. So when dyspnea appear in a patient with aortic valve stenosis, his lifespan is maximum 2 years. So 5, 3, 2, ASD, angina, syncope, dyspnea. So here evidently the bad prognostic factor or less survival factor is heart failure, which corresponds to dyspnea. So because aortic stenosis will be asymptomatic for long periods, even for 10 to 15 years, severe aortic stenosis can be asymptomatic, and 5 to 10% of patients become symptomatic every year. Okay, so most common symptom is angina because of increased oxygen demand and left ventricular hypertrophy, then pre-syncope, syncope, and finally it is a dyspnea when LV failure sets in. Okay. Now, next is a 2-year-old child with VSD, mild PH, cardiomegaly on chest X-ray, QPQS 2:1. What is the best management? So here the options are, one is to close the VSD, then an echo, cardiac catheterization, observation. So two are investigations, mere investigations. One is medical management and one is surgical management. So for that, we should know what are the indications for surgical management in a VSD. Okay. So the indications for surgical management is, one is symptomatic patients with a refractory congestive cardiac failure may require VSD closure in the newborn period itself. Otherwise, at any age, the indication for a VSD to be closed is, one is cardiomegaly with presence of left right shunt more than 2:1, or increasing PAH, development of aortic regurgitation, infective endocarditis, or development of infundibular PS. Okay, very small VSDs can be medically followed up for spontaneous closure. But here in this question, you are clearly given that the child has cardiomegaly. The child has cardiomegaly, and clearly the QPQS is double, 2:1. So there is no confusion. The answer is a VSD closure. There is no role for observation in a 2-year-old child with cardiomegaly and this much QPQS. Transesophageal echo, definitely, transesophageal echo is not an indication for this condition in a 2-year-old child. We do a transthoracic echo. And cardiac catheterization is not indicated in this child because in echo, there is only mild pH. Okay. And echo X-ray shows cardiomegaly. If the situation or if the question was a 2-year-old child with VSD, severe PAH, normal heart with a QPQS 2:1, then you should suggest a cardiac catheterization, because severe PAH with absent cardiomegaly means it may be a progression towards Eisenmenger. Okay, so here definitely the left to right shunt is more, cardiomegaly is there, PAH is mild in an echo. There is no indication to proceed to a cardiac catheterization in this child, and observation is not an option because it is a definitely this VSD should be closed. So the option is VSD closure. Okay. Now, reverse 3 sign of coarctation. I am not sure what are those options given in the question. What was the question itself? I don't know. But I will tell what is reverse 3 sign of coarctation. So, coarctation has 2 signs. There is a 3 sign as well as there is a reverse 3 sign. Okay. So, here you can see the figure of 3 sign is in an X-ray where you see there is a middle narrowed area of a coarctation. The pre-coarctation dilatation and post-coarctation dilatation will be evident as 2 bulgings. So in an over-penetrated X-ray, you can see a 3 sign as shown in this picture. Okay. And this is a reverse 3 sign, or it's otherwise called E sign. So this is seen in a barium study. It is the indentation produced by the pre-coarctation segment and the post-coarctation segment on the esophagus. Okay. So this is seen in the esophagus, seen in a barium study, and it is produced by indentation of the aorta onto the esophagus, okay, in the posterior mediastinum. So that is called a reverse 3 or E sign. I think any one of these might be asked in the options, because I don't know the options, I don't know what is the answer. So this is what is called a reverse 3 sign, okay. Now next is 70% stenosis in proximal left anterior descending, 50% right coronary. What's the management? So here, this is a very confusing question actually. If you ask any practicing cardiologist or cardiac surgeon, a single vessel lesion with a 70% stenosis, 100%, everybody will think it's angioplasty. But you have to answer according to the guidelines which is given in your textbooks. So this is the management of CAD. Given in the Sabiston textbook of surgery, the latest Sabiston textbook of surgery. So here, when you see your option, that is, this is a single vessel disease, or actually 2 vessel disease, because the LAD has 70% and RCA has 50%. So it's a 2 vessel disease, but there is involvement of proximal LAD. Okay, so this your question comes in this box. And what is the management? Class 1 is CABG, and PCI or angioplasty has a very low grade of recommendation, class 2B. So for this, there is no confusion. Your answer should be CABG. Okay. And they have given this in another chart also. Here you can see 2 vessel disease with proximal LAD lesion. CABG is the class 1 indication. And if there is 2 vessel disease without proximal LAD, the LAD lesion is mid or distal, then also CABG comes above PCI in recommendation. So here in this question, for a proximal LAD lesion with insignificant right, the answer is CABG.
Ma'am, in chat they're mentioning triple vessel disease was mentioned, ma'am, in the question.
Question was triple vessel disease.
Yes, ma'am. They're saying that was mentioned.
Okay, so triple vessel disease, then the CABG is anyway the indication. Whatever, whether proximal LAD involved or not, if it is a 3 vessel significant disease, answer is always CABG. People put multi-vessel stenting, but that is out of the recommendation. But for exams, you have to follow this recommendation. So any triple vessel disease, first option is CABG only. Okay, next is image with aortofemoral bypass with dacron graft. What is the true statement? So here I have to get the image to say what are they asking for, because here it is written graft is tunneled intraperitoneally. Okay. So we have to see the picture, then only we can tell whether the graft is tunneled intraperitoneally or retroperitoneally, because aorta is a retroperitoneal structure. In aorta bifemoral bypass, most commonly we go by a midline laparotomy and we open the peritoneum, and transperitoneally only we go and we open the posterior peritoneum and then we approach the aorta and place the graft. So let us see the other options. They have asked what is the true statement. I have three options. One is posterior peritoneum is covered over the graft to prevent leak. So posterior peritoneum is covered over the graft, not with the intention of preventing leak, but with the intention of preventing a jejunal or a bowel to vascular fistula, because later on it can lead to aortoenteric fistula. If this dacron graft is lying in close relation to the bowel for a long time, it can erode into the bowel and can lead to aortoenteric fistula. So we cover the graft with the peritoneum with an intention to prevent the aortoenteric fistula, not in an intention to prevent the leak. So this statement is not clearly true. Second is graft is tunneled intraperitoneally. For that, I have to see the diagram, your image. Then only I can tell whether it is tunneled intraperitoneally or retroperitoneally. And third option is midline incision is preferred over transverse incision. That is true, because aorta bifemoral grafting, one side may be done with the transverse incision, aorta one side femoral, but usually aorta bifemoral is done with a midline incision. That is the preferred incision. So C is a correct statement. But so I think in the image provided, it may be tunneled retroperitoneally, because the first statement is anyway wrong. Okay, so this is a diagram of an aorta bifemoral grafting, and we can tunnel it retroperitoneally in order to avoid a aortoenteric fistula. And usually we do a midline laparotomy, because we have to approach the infrarenal aorta as well as then it had to tunnel it down. So we use a midline laparotomy. Now, patient with pericardial tamponade, treatment is by pericardiocentesis and exploratory surgery. This is also, with the question given to me, it's an incomplete question, because pericardial tamponade management depends upon the cause for pericardial tamponade. Because pericardial tamponade can be due to so many reasons. It can be a slow accumulation pericardial tamponade due to tuberculosis, malignant pericardial effusion. In such situations, the treatment is pericardiocentesis, because it's a chronic problem. Okay, but if it is caused by a trauma, immediate blunt injury thorax, or a penetrating injury thorax leading to pericardial tamponade, then the option is exploratory surgery. So what caused this pericardial tamponade, then only we can tell what is the option. Okay, because in emergency, when the patient comes with the pericardial tamponade, the first option is always to aspirate the pericardial space with a ECG or echo guided, but that is not the situation in the case of a penetrating trauma. In penetrating trauma, you have to do an emergency sternotomy and a surgical management. Chronic effusion, obviously pigtail incision. So if it is not specified, you can write pericardiocentesis. If it is specified that when a trauma, the answer is exploratory surgery. Okay.
They're saying it's penetrating injury.
Penetrating injury, there is no confusion. It is surgical management. Okay, it is surgery. You have to do an exploratory surgery because it is blood and you have an actively bleeding cause there. So there is no point in aspirating it or doing a pericardiocentesis. Okay, patient will crash. So that is an even indication for emergency room thoracotomy when you have a pericardial penetrating trauma and pericardial tamponade. Okay. Now, this a CKD patient, a non-healing ulcer toe, creatinine deranged, absent popliteal and femoral pulse, the management. So, I don't have the options, but let us see the situation. Okay, so CKD patient with a deranged creatinine. So, we know for any intervention procedure, need a lot of dye injection. So that is detrimental to the patient because it's already a CKD with high creatinine. Okay, and popliteal is absent, femoral is also absent. So that means the lesion or the obstruction is high up inside the abdomen. So there may be a common iliac occlusion or a external iliac occlusion or a common femoral occlusion above. Okay, so because all these pulses are lost. So in such situation, surgery will be the most preferred option. But since I don't have the options, I don't know exactly what they mean. When we see the
options. One is CO2 angiography and angioplasty. Then hyperbaric O2 is the other option. And they're also saying pedal pulses were absent.
Pedal pulses were absent. So all the pulses absent, no? This femoral, popliteal, pedal, all pulses are absent. That means there is significant occlusion high up with absent collaterals. There are no enough collaterals also. That is why he doesn't have any of the pulses down also. So is there an option of surgery in the among the options?
Yes, ma'am. They're saying amputation was there.
Amputation. But for amputation, you should have some ischemic changes, irreversible ischemic changes and all. Otherwise, just with an absent pulse, nobody do an amputation, right? Because when you see the task classification, you have a type A lesions, type B, type C, and type D lesion. You see, type A is high up single lesions, type B is bilateral lesions, type C is multiple bilateral lesions, and type D lesions are also combined long segment lesions. So usually a type A lesion, single unilateral lesions are endovascular is the treatment of choice. But when you come down or the lesion is significantly long or multiple, surgery becomes the preferred option. So angiogram and angioplasty may not be the preferred answer here because the patient is there specifically told the patient is a CKD patient with high creatinine. So, and they have not told the patient is on dialysis. If the patient is on dialysis, then that's not a problem. But otherwise, with a single angiography, the patient will end up in dialysis if he's not so. So, amputation, that is a very vague question with a vague. One is, what is it? CO2 angiography with angioplasty, right?
Yes, ma'am.
Okay, so that is an option because they are not using dye. CO2 is used. And second option is?
Toe amputation is what they have mentioned, ma'am. Then hyperbaric oxygen treatment.
No, hyperbaric oxygen and all are management of ulcers. Here they are not told about ulcers and all. So there is no role of hyperbaric oxygen for just ischemic limb. And the third is amputation, third toe amputation. That is
They've also
not
mentioned the toe pressure of 24, ma'am. I don't know.
Toe pressure of 24 means it is a critical limb ischemia. Yeah, a critical limb ischemia. You have to intervene something, but this is a non-healing ulcer. There are written non-healing ulcer management. Okay. Non-healing ulcer toe pressure 24. Toe pressure 24 means the ulcer won't heal.
Yes, ma'am. Femoral and popliteal pulse was present, they're saying, ma'am. But
absent popliteal and femoral pulse. No, this is the question. No.
I think the question might have been wrong, ma'am. They're saying it was present, and
there is another question with the pulse present. There is some other question is there with pulse present. Okay.
Yes,
so because there's a lot of confusion in this question with the ulcer toe with absent popliteal femoral means the whole limb pulse is absent. There is high up obstruction inside the abdomen. So if the popliteal and femoral pulse is present and distal, then the situation changes. So can you get a correct question at least by the end of the session? Then we can rethink on that.
Yes, ma'am. We'll move on to the next question.
Okay, next is a young girl, fingers turned blue to cold while screening markers of associated rheumatological disease negative. How will you explain prognosis to her? It is Raynaud, upon progress, it may worsen leading to cutting a finger. So here, basically, they are trying to explain that it's a primary Raynaud syndrome. Okay, so a primary Raynaud syndrome means it is sympathetic activity that they are more when they are exposed to emotional stress, cold, vibration, etc. There will be vasospasm. It's a primary vasospastic disorder without any associated underlying causes. If there is any associated underlying causes like rheumatological or connective tissue disorders, that is called a secondary Raynaud's. Okay. So here they are telling that these screening markers are all negative. That means they are trying to convince that it is a primary Raynaud's. Okay. So primary Raynaud syndrome has actually a good prognosis, no mortality and very minimal morbidity. But secondary Raynaud syndrome, where there is an associated underlying cause like connective tissue disorders or rheumatological issues, that can lead to tissue necrosis and that may require amputation of the digits or so. So here it is Raynaud's, it won't progress. That I think that may be the apt answer as they tell it is a primary Raynaud's. Okay.
They're saying the other option is psychological cause, and yes, ma'am.
It is not psychological. It is not psychological cause. Emotional stress can precipitate it, but we cannot tell that Raynaud's is a completely psychological cause. Now, toe angle pressure less than. This is actually confusing. Whether they are aiming at toe pressure or angle pressure, because both are different. Both have different values. Okay, and CTLI, it may be a chronic limb threatening ischemia, or CLI, which is a critical limb ischemia. So anyway, we can consider both to be almost nearby terms. And the CBF, I don't know. Well, actually, the pressure less than should be the question, 50, 70, and 30. So here, the correct pressure is not given in Bailey or Subison, but in Schwartz, they have written that ischemic rest pain occurs below an ankle pressure of 50 millimeters or a toe pressure less than 30 millimeters. So both these options are there, 50 and 30. And the question I have been given is toe ankle pressure. So I am really confused. And the second option, if this is for rest pain, patients with the rest pain, the ankle pressure less than 50 or toe pressure less than 30 will be these pressures. But for patient with ulcer or gangrene, the presence of a critical limb ischemia is suggested by an ankle pressure less than 70 or a toe systolic pressure less than 50.
Ma'am,
So here again,
both were asked, ma'am. They're saying ankle 70, toe 50, ankle 50, and toe 30.
Okay. So, and here again, the problem is whether both this chronic limb ischemia or critical limb ischemia can have ischemic rest pain or
No rest pain is they're mentioned.
ulcers. So if you take ulcers, then the answer is ankle pressure less than 70 and toe pressure less than 50. So that may be the answer. The critical limb ischemia, when you consider ulcers or gangrene, this is what the definition given in Schwartz. So we can take this when the angle pressure is less than 70 or toe systolic pressure less than 50. So that may be the answer. This is not an isolated. I think both the pressures are given, right? That's what you are telling.
Yes, ma'am. That's what they're mentioning.
So this may be the answer. Angle less than 70 and toe less than 50. Okay. Okay. The other one was a diabetic patient with an ABPI more than 1.3 presented with ulcer. Pressure in the toe maybe less than 26, palpable, popliteal, and femoral. What will you do? This may be the question confused with the earlier question. Here, popliteal and femoral are palpable. And I have given only two options, angiography and angiography with angioplasty.
Yes, ma'am. That's it's the same question, ma'am.
Both are the same question.
Yes.
So the diabetic patient and CKD patient with high creatinine, both are present in same patient.
Yes, ma'am. They're saying it's the same question.
Oh, okay. So then angiography, and then the option will be CO2 angiography with angioplasty. That was told earlier. CO2 angiography with angioplasty.
Yes.
Okay. So ABPI more than 1.3 means it is a heavily calcific vessel. Normal ABPI is 0.9 to 1.3, or some books say 1.4. But a high ABPI in a diabetic CKD patient means the vessel is heavily calcified. So heavy calcified vessels may not be amenable to angioplasty, because the moment you put in a stent and you try to dilate it, the vessel will rupture. Okay, that is a problem with heavily calcific vessels. And these are small vessels. You have a palpable popliteal. So that means your small vessels are affected. Either it will be an anterior tibial or a posterior tibial or a toe or a distal vessel, which is heavily calcified with high ABPI. I don't think angioplasty is a good option. And a non-healing ulcer may, one is a hyperbaric oxygen and second is toe disarticulation. That was the option, I think. Toe disarticulation, non-healing. Finally, it may land in that, but hyperbaric oxygen may be tried, but it is a really confusing question. What they actually mean, I'm also not sure. Fourth, because I feel angioplasty should not be an option for that, being a heavily calcific vessel and a very small vessel. That is posterior tibial and anterior tibial vessels, when they're heavily calcific and small, because these patients are having diabetic vasculopathy. So those small vessels may not be amenable to angioplasty. And being calcific, there's a high chance of rupture also. It will lead to hematoma and loss of limb. So either hyperbaric oxygen therapy or toe disarticulation. But just with an ulcer, we cannot tell straight away toe disarticulation. So any attempt to attempt to heal the ulcer should be given the priority. So in that case, hyperbaric oxygen may be tried. So this is just when I thought these two are the options. You can see in this picture. First, for any limb ischemia, we do a duplex ultrasound and followed by CT angio. But here specifically, CT angio is not recommended for infrapopliteal visualization, especially in a diabetic CKD patient, because the vessels will be heavily calcified. So CT angio will not be able to show you the lumen. Okay, so definitely you have to go for a diagnostic catheter angiography or a detailed foot MRI. Okay, so angiography is obviously not an option in this. CT angio is not an option. Angiography may be an option, but management definitely requires some method to heal the ulcer. Okay, so I think maybe hyperbaric oxygen may be the option. Now, cardiac transplant rejection donor-specific antibody. I don't know what's the question, but I have put a slide on the transplant rejections. You know, there are three types of rejections. One is a hyperacute rejection, acute rejection, and chronic rejection. So hyperacute rejection usually occurs inside the theater. As soon as you finish your anastomosis, the heart will turn black or purple. There will be multiple hemorrhages in the heart, and there will be heart myocardium will become edematous, and patient will not come off bypass after the surgery. That is after the transplant, implantation of the heart. So that usually requires a retransplant, or sometimes we can be tried on ECMO for some time. That is because pre-existing immunogenic or antibodies against the donor antigens. And second is acute rejection. Acute rejection, two types: cellular rejection and antibody-mediated rejection. So your question says it is a donor-specific antibody. So I think which of the rejection is diagnosed by donor-specific antibody? Then the answer is a acute antibody-mediated rejection. Here, the donor antigens and the recipient antibodies form an antigen-antibody membrane attack complex and will cause extensive endothelial injury. Okay, and the diagnosis of antibody-mediated rejection is confirmed by the presence of circulating donor-specific antibodies with complement activation. So, this is the donor-specific antibodies are checked to diagnose acute rejection, which is antibody-mediated rejection. Then the chronic rejection is called chronic allograft vasculopathy. It is a long-term complication, and that pathogenesis is mainly immunological and ischemia reperfusion injury. Okay, so this may be one of the options given to diagnose antibody-mediated rejection. Okay. Now, graft with best 10-year patency, Lima, Rima, SVG, obviously it is the Lima, because Lima, the 10-year survival is 95%, 20-year survival is 90%. Rima has a 5 to 10% less than this. 10-year survival may be around 90 and 20-year survival may be around 80 to 85%. Venous graft still very low survival, 1 year 90, 10-year is 60 to 70. So there is no confusion. Best 10-year patency is left internal pancreas. Now, agent used in MR lymphangiography, this is the option given. This is the dye which is used in MR lymphangiography. So obviously, I think somebody has given the correct option alone. Remember the correct option alone. This is the dye used in MR lymphangiography. So these were the questions given to me, and I think one or two were very confusing. I cannot figure out what they exactly mean, but others are rather straightforward questions. Is there any doubts?
One doctor is asking carotid transection of 2 centimeter. What is
Carotid?
Carotid transection of 2 centimeter. What is the management option? He's asking.
2 centimeter, actually, common carotid, 2 centimeter may not be able to for a direct anastomosis, because that much length may not be available. If you mobilize and do it under tension, there is a post-operative problem of carotid blowout. So the option is you can use a venous reconstruction. Usually we prefer saphenous vein. Is that in the option, saphenous vein?
Yes, the question is common carotid injury with transection and defect of 2 centimeter. Options are venous graft, anastomosis, and Dacron graft. These are
venous graft will be the preferred one. Venous graft.
One more question is NYHA2 non-calcific pliable valve MS management.
Calcific pliable valve.
Yes, ma'am.
NYHA2 calcific pliable valve.
Non-calcific, I'm sorry.
Huh?
Non-calcific.
Non-calcific. Is it a severe MS? Is it written severe MS?
No, they have just mentioned MS management. No, it's not severe.
Okay, because only severe MS needs management. Mild MS, moderate MS, no intervention, just observation. So if it is a pliable non-calcific valve with MS, if it is not mentioned severe, then follow. If severe MS, PTMC, that is percutaneous transmitral commissurotomy. Because if they specifically told it is a pliable non-calcific valve, then PTMC or intervention commissurotomy is the treatment, but only if it is a severe MS. Symptomatic means okay, and NYHA2 symptomatic severe MS means management. And if it is a symptomatic severe MS, treatment is PTMC.
They're mentioning patient had dyspnea too, and one of the other option was balloon valvotomy.
That is balloon valvotomy. Yeah, that is PTMC, balloon valvotomy. Same as PTMC. The only indication for surgery in mitral stenosis is severe symptomatic mitral stenosis, which is not amenable to balloon valvotomy. That is the only indication for surgery. Otherwise, all situations they advise balloon valvotomy. And earlier, actually, in pregnancy, surgical management was preferred in third trimester. But now, in early pregnancy, you can use an abdominal shield, and still balloon valvotomy can be done if symptomatic severe MS is there.
Ma'am, they're asking what would be the final answer, observation or balloon valvotomies for that?
Symptomatic MS. So since they have written it is NYHA class 2, we have to assume that it will be significant MS. Otherwise, the patient will not be symptomatic. So symptomatic, because they are given NYHA 2, we can assume it is a symptomatic severe MS, significant MS, then balloon valvotomy with option. If it is asymptomatic, we can observe, but symptomatic patient, I need to verify the, 1 second, I need to verify the chart whether NYHA class, yeah, symptomatic is included NYHA class 2, 3, and 4. Yeah, I remember it is 2, 3, and 4 are included in symptomatic MS. So balloon valvotomy may be the answer. Because it is symptomatic, we have to assume it is significant MS.
They're saying there was a question on carotid body tumor in base of skull, ma'am.
Okay.
Can someone elaborate on the question? Proximal extension, how to get this?
Proximal extension?
How to get, that's all they're mentioning on.
How to get the proximal extension at the base of skull?
Yes, ma'am. Options, nasotracheal intubation, CI. Mandibulotomy.
Second, what is the second option?
Mandibulotomy.
Mandibulotomy, then?
Then PVA and embolization. And mandibular subluxation.
Mandibulotomy may be the option because you have to get the proximal control, no? So subluxation may not give you exposure. Then this embolization will not give you the exposure. You have to get the, if you're planning for surgery to get the exposure, embolization will only decrease the blood flow and prevent bleeding to some extent during surgery. And the first option, what was that first option?
They're saying the question was except all or except none, like which out of the options, which is the exception, I think. So the PVA and embolization was one of the option. Mandibulotomy, then mandibular subluxation.
The fourth option?
Only 3 options they are mentioned. Can somebody tell me the fourth option? Embolization and nanotracheal intubation. Sorry, nasotracheal
intubation.
Yes.
Nasotracheal intubation. Embolization may be the option because to get the proximal extent, How will embolization help to get the extent? I'm not sure, because embolization is usually done to prevent the bleeding or decrease the bleeding during the surgery. The other options, okay, mandibular subluxation, mandibulotomy will all help in getting access to the distal most part of the carotid artery. And nasotracheal intubation. Nasotracheal intubation, how it but embolization is an odd man out, I feel. Because you have to resect the entire tumor, then even if you embolize the vessel, you cannot limit the resection to half the tumor. So, but I will again go through that, and I will refer the higher textbooks, because very little is given in all textbooks about carotid body tumor. I will get back to you because if there is any change in this, I will refer to this. Okay. So the such questions, can you just put to me so that I can also refer other textbook also and try to find out the answer? Okay.
Yes,
And we are also confused what they actually mean, because somewhere it should be written. So I will refer to it and get back to you. Okay.
Yes, ma'am. I think that is it.
Okay.
So
Further, if there are any questions, please collect all those and then put to me, so that I can at least, even if not in the webinar, I can just prepare a discussion and then share to you, so that you can give to me. Okay.
sure, ma'am. Will do. Okay.
Okay.
Thank you so much for conducting this session, ma'am. Thank you everybody for joining in.
Okay.